We've got two fabulous speakers today. Dr. Hallie Prescott is a pulmonary and critical care physician scientist based in Ann Arbor, Michigan. Hallie's work doesn't need much introduction, but she has done a tremendous amount of work looking at the longer term outcomes following sepsis. The overarching goal of her research program is to improve the management and outcomes of sepsis and sepsis survivors. And Hallie is also the co-chair of the Surviving Sepsis campaign that you must have heard about and you'll hear more about in the next few minutes. Our second speaker is Dr. Andy Conway, who is based at Cambridge. He's an MRC Clinician Scientist. Andy's work focuses on an interception between nosocomial infections and immunology, particularly focused on neutrophil antimicrobial function. And Andy is also the chair of the infection section of the European Society. So without much further ado, I'll hand over to Hallie to start with the first talk. Hallie, over to you.
Thanks so much, Manu. I'll go ahead and get my slides loaded up here.
So whilst you're loading up your slides, just a brief housekeeping. There is a Q&A box. If you have any questions, please add them as they come to you, and then we'll try and answer them during and after the talks. Thanks.
Great. Yeah, thanks so much. So really a pleasure to be speaking today. Thanks for organizing, Manu, and for moderating today's session. I'll be talking about rapid antibiotics for sepsis. Are we saving lives or driving overuse? A lot of the work that I'll be sharing today was funded by a grant from the U.S. Agency for Healthcare Research and Quality. Otherwise, I've listed sort of other funding and relevant roles. Obliged to tell you this does not necessarily represent views of the U.S. government, and just a big thanks to many collaborators and staff who really made this research possible. So this topic of antimicrobial timing for sepsis, at least in the US, has been fairly polarizing over the past few years. There are groups of people who think this is vital. This is the most important thing that we can do to reduce mortality from sepsis. But there are also groups of people who think that our intensive focus on earlier time to treatment might be overblown, and even more concerningly, maybe driving antibiotic overuse. As we know, prompt treatment is strongly recommended by the guidelines. For example, in the 2016 Surviving Sepsis Campaign guidelines, there was a strong recommendation to administer antimicrobials as soon as possible and ideally within 1 hour of recognition for both sepsis and septic shock. This was then included in the Hour 1 bundle in 2018, further underscoring its importance in sepsis quality improvement initiatives. In the US, rapid antibiotics are further incentivized by formal performance measures endorsed by our National Quality Forum and are used in a variety of sort of high stakes performance measures and policies included by our national Medicare program, as well as a variety of state-based initiatives, most sort of well-known being out of New York State. There's a fairly large body of literature that has looked at the impact of time to antibiotics and mortality in sepsis. I'll highlight one study here. This was by Vinnie Liu and colleagues at the Kaiser Permanente, Northern California. In this study, they looked at a cohort of about 35,000 patients hospitalized through emergency department with sepsis, and they looked at the time to first antibiotic administration. And in a study, which had very sort of detailed granular information about patients, so sort of very good ability to do risk adjustment, they found that each hour of delay in time to antibiotics was associated with a 1.8% absolute increase in mortality for septic shock and a 0.4% absolute increase in mortality per hour delay in severe sepsis. And I'll point out that in-hospital mortality for this group was 26% in septic shock and about 9% in the severe sepsis cohort. These findings have really been seen in a variety of other studies that use sort of similar methods to look at this very same question in different cohorts. So this has been seen in data out of the New York State Initiative, sort of a multi-hospital cohort in the state of Utah, and then in this sort of more recent study that was done out of Germany. So a variety of observational studies showing, to the best ability to adjust for confounding in these observational studies, there does seem to be this consistent signal that earlier time to treatment is associated with improved outcomes, and that impact is most important for the sickest patients, patients with shock or hypotension. There has been really just a single, I would say, randomized clinical trial that's really sort of addressed this issue. This is the Fantasy clinical trial. This randomized 2,698 patients with sepsis to receiving treatment in the ambulance en route to the hospital versus usual care, where they would receive their antibiotics at some point after arriving to the hospital and getting treated. So indeed, randomization to treatment in the ambulance was associated with getting antibiotics faster, on average about 96 minutes faster. But this did not translate into a statistically significant difference in mortality. So the treatment arm had a 0.4% reduction in their 28-day mortality, 7.8% versus 8.2%. And so some people have used this to say, oh, see, all this other literature is totally overblown. This is really not that important. And I've always had a kind of a different interpretation of this study and felt that it's actually fairly consistent with the prior studies. If you take these kind of relative risk reductions seen in the observational studies and you apply them to this less sick population, here only 3% was shock, 8% 28-day mortality, what you would expect to see is about a 0.4% reduction in mortality. And that's exactly what they found. So I do think that this is consistent. I think it's a reflection of being a less ill cohort and being a smaller sample size, such that this did not translate into a statistically significant study. So interim summary of kind of what we know from this kind of large body of literature: delays in antibiotics are associated with increased mortality. The impact of time to treatment is particularly higher for sicker patients with shock. And while there are limitations to these observational data, the findings, I think, are pretty consistent across the higher quality studies that have the ability to pretty robustly adjust for illness severity and sort of confounding by indication across patients. At the same time, we have kind of another body of literature telling us that we're not always perfect at diagnosing sepsis. So these are 3 different studies that looked at patients who were diagnosed with sepsis on arrival to the intensive care unit or on presentation to the hospital. And then they looked at what happened at the sort of end of hospitalization. And they found that really across these studies, more than a third of these patients ultimately have their diagnosis revised, such that they either don't have infection at all, or they don't have a bacterial cause for that infection, suggesting that those initial antibiotics weren't, in the end, turned out not to be sort of not to be needed. And so it's this body of literature about diagnostic uncertainty that I think has really sort of fueled a lot of the controversy in the United States and concerns that by really focusing on faster time to treatment in this condition that we struggle to diagnose with certainty in real time, that we might be driving antibiotic overuse and resistance. So there's been this whole variety of kind of perspectives, viewpoints, editorials about this issue, and they really all have the same conclusion, that our time to antibiotic targets risk promoting antibiotic overuse and antibiotic associated harms. In the US, this sort of concern really came to a head in the fall of 2021, when the American College of Emergency Physicians and a number of other professional societies came together to formally petition our National Quality Forum to de-adopt the severe sepsis and septic shock management bundle that really forms the backbone of all of these sepsis, sort of high-scale sepsis quality improvement initiatives and sort of performance measures in the US. So with that background, I think that there is really this urgent unanswered question, which was, is this focus on early antibiotics actually driving overuse, right? So the data is not perfect about time to treatment, but there's a lot of data and it's telling a pretty consistent story. And there's a lot of concerns about driving overuse, but we're really sort of scant on data showing that that's happening. So that was really the premise for this grant, to look at hospital antibiotic prescribing for potential infection. So this is a grant in collaboration with my co-PI, Vinnie Liu at Kaiser Permanente. And one of the key thrusts of this grant is trying to understand when hospitals accelerate or sort of shorten time to antibiotic delivery for sepsis. Is this change associated with rising antibiotic use or broader spectrum of coverage among all comers to the hospital who have potential infection? So in this study, it's a pretty large study. So we have 152 hospitals. So that's all hospitals in the nationwide Veteran Affairs system where I work. And so those are the dots shown on that map of the United States. Additionally, we have another 22 hospitals from Kaiser Permanente, which are all located in Northern California. The exposure is this hospital-specific trend in time to antibiotics for sepsis among hospitalizations that meet our US surveillance criteria for sepsis. And in total, across all those hospitals, we had about 273,000 hospitalizations that met surveillance criteria for sepsis. The outcome, we measured at all hospitalizations for potential infection, which we defined as people admitted through the emergency department with positive SIRS criteria. And so in total, there's nearly 1.6 million hospitalizations in our cohort over the 6-year time frame. So for this exposure, the time to antibiotics, this we calculated based on barcode medication administration records. So essentially the nurse scans the medication barcode, they scan the patient wrist badge, and then they deliver that medication. And so it really just sort of encodes the actual time that the medication was delivered, and it's pretty much as close to ground truth as you can get. So we had that data for all hospitals in our cohort, and many of the emergency departments, there are some emergency departments that did not use barcode medication administration. And so for those, we used physician order entry time plus a 45-minute sort of time from order to delivery, which we were able to show in the hospitals where we did have data that was a pretty conservative estimate. I think the median time was about 25 minutes in those emergency departments where we did have records. So when we looked across our cohort, we saw that indeed time to treatment for sepsis was declining over time. So these figures show the distribution of time to antibiotics in the early, middle, and late part of our study. And overall, median time to antibiotic delivery declined by 9 minutes per year. We looked for nonlinear trends, but at least in our sort of 6-year time frame, didn't see any sort of year upon year, on average, 9 minutes faster across the sort of cohort at large, these 152 hospitals. We saw that the slope of change did, as you would expect, vary across the individual hospitals in our cohort. So here we show 3 different sort of tertiles. On the left, hospitals that are having the greatest declines in time to treatment for sepsis, hospitals in the middle with some decline in time to treatment, and hospitals on the right in tertile 3 that were sort of relatively flat, and then even a handful of hospitals where actually time to treatment was getting longer over time. So I will now move on to sort of the sort of meat of the presentation, the findings you've been waiting for, and that is when hospitals accelerate their time to treatment for sepsis, do they prescribe more antibiotics or broader antibiotics kind of at large to patients at risk for infection? And so essentially for this analysis, we're trying to associate these differences in these hospital-specific trends with hospital-specific trends in antimicrobial use, days of antimicrobial therapy, broadness of coverage, again, to patients, coming in through the emergency department with positive SIRS criteria. And so we want to ask, do hospitals with greater declines in time to treatment for sepsis have increasing antibiotic use, sort of showing that there is antibiotic use, as people have warned about in many perspectives, editorials, viewpoints? Or alternatively, less robust declines in antibiotic use? Maybe everyone's declining, but those declines have been less smaller in the hospitals who are accelerating time to treatment, suggesting that, okay, it's not driving overuse, but it's impairing antimicrobial stewardship efforts. So first, we looked at sort of overall trends in antimicrobial prescribing among the SIRS positive hospitalizations. And we saw in this 152 hospitals that antimicrobial use generally was declining over time. So when we looked at antimicrobial use within 12 hours of presentation, sort of arrival to that emergency department, we saw that there was a slight uptick in the proportion of patients treated within 12 hours. But when you kind of zoom out and look to 24 hours, it's no different. And when you look to 48 hours, there's actually a slight decline in the proportion of patients treated. When we look at the mean days of therapy across all patients coming in with positive SIRS criteria, we see a pretty significant decrease in median days of therapy at 0.6-day decline for the whole cohort. And then the proportion of patients specifically being treated with broad spectrum coverage kind of early or ever kind of associated with their hospitalization, we see that those declined over time. So I think overall suggesting that there has been a decline in the sort of broad use of antibiotics in hospitalized patients. So do these trends differ depending on the hospital's trend in antimicrobial timing for sepsis? So we looked at this kind of association between trends a variety of different ways. Spearman's correlations, robust regression, and really any way we looked at this, we did not see that there was an association between what was happening with sepsis and what was happening more broadly for antimicrobial stewardship. So here, I'll show you in this next slide, one sort of figure that sort of tries to graphically show the relationship between these trends. So in this figure, each dot represents one hospital in our cohort. And so these hospitals are plotted on the x-axis based on their yearly change in time to antibiotics for sepsis. So here, 0 would be no change over time. And then as you go further to left, these are hospitals that are sort of getting faster and faster over time. And then on the y-axis, we have the yearly change in average days of antimicrobial therapy for all SIRS-positive hospitalizations. So again, 0 here would be no change in sort of average days of therapy. And as you go down here, that means that they're having declining antibiotic use over time. So you'll see that the vast majority of hospitals fall in this bottom left quadrant, suggesting that they are simultaneously having faster time to treatment for sepsis and decreasing days of therapy being prescribed to their SIRS-positive hospitalization. So I think this is like very positive news, showing that it's possible to simultaneously improve sepsis care and antimicrobial stewardship, which I think people have really historically thought are sort of two opposing things, and it's going to be difficult, and that they're sort of going to be, counteracting efforts. So summary of our findings, we saw that time to antibiotics across the 6 years declined by 37 minutes, slight increase in the proportion of patients treated within 12 hours, but a decline when we looked out to 48 hours. Days of therapy declined by 0.6 days, and use of broad spectrum coverage, across a variety of different definitions, declined by about 2 to 4% of absolute. Importantly, these hospital-specific trends in sepsis timing were not associated with hospital-specific trends for other aspects of antimicrobial prescribing. So takeaways from this data: faster antibiotics for sepsis did not drive indiscriminate antibiotic use in our cohort, and faster timing of antibiotics for sepsis did not appear to be impairing stewardship efforts. We saw pretty consistently across the hospitals declining use of antibiotics. So I think this has important implications for guidelines and for performance assessment. So certainly it's possible to shorten time to antibiotics without driving overuse and impairing stewardship efforts. And I think that this data supports the sort of feasibility and appropriateness of still using time to treatment for sepsis performance assessment, despite these kind of many concerns that had been voiced about it driving antibiotic overuse. So implications for bedside care. I think all of these data are really supportive of the updated recommendations or sort of framework for considering antimicrobial timing from the Surviving Sepsis Campaign guidelines. So on the bottom left, I show the prior recommendation from 2016 saying, treat within as soon as possible, ideally within 1 hour. I think that that was a little bit hard to implement in practice because of this issue of diagnostic uncertainty that I discussed a little bit during this presentation. And so this new framework tries to address that, to make sort of more actionable or sort of easier to implement guidelines in practice. So if you think the patient has sepsis, we use the language sepsis is definite or probable, give antibiotics. That's just like the recommendation from 2016. But we recognize there may be people that you see in your emergency department or show up to the intensive care unit where you're really not sure. For those patients, we recommend stratifying them based on whether they are in shock or not. And that's based on the data showing that shock, each hour of delay is sort of associated with much more potential harm in patients who are septic. So we recommend that if shock is present and you don't have a very clear reason to explain that for other causes, administer antibiotics immediately, ideally within 1 hour of recognition. Of course, continue to look for other causes of illness, and if it turns out to be something else, stop the antibiotics. And then if sepsis is possible, shock is absent, we now recommend rapid assessment of non-infectious and non-infectious causes of illness with a goal to make a decision and administer antibiotics within 3 hours if the concern for infection still persists. So essentially, exam, more history and x-ray. I mean, there are things that I think can be done in those 3 hours that may help you sort of further risk stratify and make a better decision rather than to feel like, maybe it's sepsis, I need to decide immediately whether to give antibiotics, otherwise I'm going to miss my 1 hour. So I will close there. And I'm happy to take questions. I think we're going to move to our next speaker, but would encourage you all to sort of drop questions in the chat, or the Q&A, sorry, the Q&A. And I'll look forward to having a discussion a little bit later on in this session. Thanks, everyone.
Thanks, Hallie, for a fabulous talk. I think, as Hallie says, please add your questions in. Over to you, Andy, for the next talk.
Great. Thank you very much, Manu, and to the ICS for the invitation to speak. While I just get my slides up. Okay, so thank you very much. A slight change in track now for the second talk. I'm going to discuss really what we've learned over the last couple of years from our therapeutics in COVID, and ask the question: can we translate this into therapeutics for bacterial sepsis? So these are my conflicts of interest, and broadly what I'm going to go through is just briefly review the proven therapeutics in COVID-19, and I'm sure you're all very familiar with those and the guidelines and so forth, so I won't labor that point. I then want to get in a bit to the pathophysiology of COVID-19 and how this might differ from bacterial sepsis. Now, this is not going to be an in-depth immunology talk, so I know Manu will be disappointed about that, and everyone else will sigh a massive sigh of relief. But we'll keep that relatively light, and then talk about what can be translated from COVID-19 into bacterial sepsis. And perhaps I've already given away my conclusion by saying the final bit will be a little bit talking about future trials. So I think the first thing we should recognize is that whilst in the UK and indeed in the United States and several other countries, COVID-19 has been a massive disaster and has caused untold morbidity, mortality, and misery for millions. At another level, it's been a massive success, and where that success has been in the form of therapeutics. So to put it into context, if we take tuberculosis, first identified as an illness millennia ago, but the pathogenic organism not identified until 1882, Robert Koch. We then have to wait another 60, 70 years until we start getting therapeutics. And indeed, it's not until 1948 that we see the first sort of proper trial. And indeed, it's later still that we then get, in 1952, we get an effective therapy in the form of triple therapy. Now, contrast that with HIV. So HIV or AIDS, first identified as a disease, late 70s, early 80s. HIV as a virus, identified in 1983. First treatment trial, 1987, AZT, not massively effective. And it's really, it's over a decade later before we have an effective therapy for HIV in the form of highly active antiretroviral therapy. Now, I've put these slides in, or these timelines into scale. And I can't actually fit the COVID one in because, or at least not make it legible, because with SARS-CoV-2, we had a virus that emerged probably sometime in sort of mid to late 2019. It's identified in late 2019. Rapidly, the virus is identified sequence. That sequence is distributed around the world, so we have effective diagnostics within, a month. And the first trial is published in, showing successful treatment in less than a year, around about 6-7 months after the virus is first identified. And of course, we've then seen subsequent trials over the space of about 2 years. So it's a massively compressed timeline. And given that we've had a sort of 30-40-year history of miserable failure to identify effective therapeutics in bacterial sepsis, it is tempting to say, well, we found something, and let's be honest here, COVID-19 is sepsis. Yeah, it's an infection that leads to organ failure due to dysregulated immune system. So if we can knock the COVID isn't sepsis into a cocked hat, it is. But can we translate these results straight into bacterial sepsis and sort of shortcut that 30 years of well, I say faffing around? That's doing a disservice to all the people who've done huge amounts of work over the years, but 30 years of failure. Well, let's have a look briefly at what works in COVID-19. So vaccines work. That's great. Not particularly applicable in ICU in a patient who's already got sepsis. So yes, there are vaccines obviously for bacteria, and they definitely have an impact in preventing patients getting infections and in preventing patients getting sick. But by the time the patients hit us, it's a bit late. Glucocorticoids obviously was the first one to be identified as an effective therapy, followed by IL-6 blockade, particularly with tocilizumab. More recently, we've had firmer data on JAK-STAT inhibitors, mostly baricitinib, and antivirals, if given early, and I'll come back to that a little bit later on in the talk, recombinant antibodies in patients who are seronegative, so who haven't mounted their own immune response by the time they're seen, and anticoagulation, but probably not in patients who are in ICU. And a little bit of debate as to why that might be, whether it's due to adverse bleeding risks being higher in ICU patients, or that they're at a different stage of the disease, I think is unclear. What probably doesn't work, and I've put that probably in brackets there, because I think some of these are still areas of active research. So anti-GM-CSF and inhaled GM-CSF, so both approaches have been tried, and there's reasonable rationale for having tried both approaches. It's not completely mad, but probably don't work. A couple of trials coming out soon that I think will be interesting in that area. Interferon-1 beta, again an inhaled drug, probably didn't work, certainly not in the phase 2 trials. IL-1 blockade and TNF blockade. So it's interesting because it's not, obviously IL-6 blockade is very effective, but it's not just sort of broad spectrum hitting any pro-inflammatory mediator that you can block, and that's probably, and we'll come on to discuss this a little bit, about the timings of when these cytokines are released, and then a whole collection of other drugs with a diverse range of potential mechanisms of action, all of which have been shown not to work in well-conducted trials. So thinking briefly about why things might work, why some drugs might work, and whether we might be able to apply it to bacterial sepsis, I think it's really important to acknowledge the rather specific nature of COVID in terms of the temporal profile. So what we see in COVID is that you get infected, you have a pre-symptomatic phase where you're actively shedding virus, you are definitely infectious, probably one of the reasons why this spread so effectively around the world, and probably spread faster than SARS-1 and MERS-CoV. And really at the point where you've got peak viral production, the patients are fairly oligosymptomatic. They're not feeling too unwell. And it's as the viral titers start coming down and you become less infectious that you start to get more unwell. And it's typically the patients who come to us in the intensive care unit sort of 10 to 12 days after onset of symptoms is when they get really properly sick. And I think this is really important, because if we have a look at steroids in COVID-19, and glucocorticoids obviously is what I'm talking about, and this definitely a class effect, but let's have a look at the recovery trial, because it was the first one, and I think also has one of the most interesting findings in it. So dexamethasone reduces mortality in patients with COVID-19. Okay, I don't think that's a controversial statement. But what's interesting when we look in this study is we look at the patients who weren't on oxygen. Okay, and there is a signal there that they do worse with steroids. Okay, so overall everyone does better, but when you look at the patients who are not on oxygen, they do worse. Okay, now is that just because they weren't that sick? Well, if you look at the days to symptom onset, you can see that the patients who are not getting oxygen are a couple of days earlier than those who are getting oxygen, and several days earlier than those who are in ICU and in invasive mechanical ventilation. So if we go back to this diagram here, you can see here, this is the time period where patients who are not on oxygen, who do worse with steroids, are. Okay, so they're in this bit here as the virus is still actively replicating. Whereas when we look at the ventilated patients, who are the ones who do the best with steroids, they're at this stage here, and basically viral replication has stopped. And I think this is really, really important, okay, because I think it tells us something, not just about COVID, but also about bacterial sepsis, because now the other side of this is the antivirals, and it tells kind of the same story, but from the other direction. So if we look at the original report of remdesivir in COVID-19, and we look at the sickest patients. These are the patients who are on mechanical ventilation or ECMO, who are the latest in their disease course. The remdesivir does absolutely nothing. Yeah, total waste of time. Do not give this, okay, in this group of patients. However, when we look at the early group of patients, so these are patients who are treated pre-hospitally, it's a group of patients who are at high risk of severe complications. And here the outcome is different. So we're not looking at recovery, we're looking at hospitalization or death from any cause. We can see here that in this group of high-risk patients, remdesivir is effective. And this is because it's targeting that period of time during which there's active viral replication. So my sort of take from this is that viral proliferation is distinct and precedes symptomatology. Okay, that's, again, it's not my conclusion, that's the conclusion of the body of scientific knowledge on this. And the antiviral treatments work, but only if given early, i.e. when the virus is actively replicating. Conversely, immunosuppressive therapy works, but is most effective when the immunopathology is marked and the viral replication is reduced. And indeed, early immunosuppressive therapy might be harmful, possibly because it's reducing your antiviral immunity. Now, not proven, but I think reasonable evidence there to support that contention. So let's change tack a little bit and think about bacterial sepsis. So bacterial infections are usually, at least when we can get effective cultures, characterized by culture of bacteria. And for order for bacteria to be cultured, they have to be viable and rapidly proliferating. Okay, if they are in a dormant state or have already been killed by antibiotics, you won't get a positive culture. Now, that's different from viruses, which we tend to detect these days by PCR, and that PCR persistence will persist long after they're infectious. So when the patient presents to us in the intensive care unit or slightly earlier in the emergency department with bacterial sepsis, they have almost certainly got ongoing active bacterial replication. Now, as I say, I'm not going to go too heavy on the immunology, but just to briefly cover the differences perhaps between COVID and bacterial pneumonia as the bacterial disease I've chosen, because it's my favorite bacterial disease. So viruses signal via viral pathogen-associated molecular pattern receptors, so things like RIG and the toll-like receptors 7 and 8, as well as indirect cell damage signaling, so virus-induced cell lysis, release of damage-associated molecular patterns. We get a lot of interferon signaling, both type 1 and type 2 signaling, immune cell recruitment, and reasonable evidence that certainly in the lungs, we see a macrophage and monocyte predominant inflammatory picture, which is different from bacterial pneumonia. We see cytokine release, and again, I've just sort of waving my hand and say cytokines, but we could get a bit more specific about that. But a wide and broad range of cytokines are released. And in a lot of patients, we see features of what we call macrophage activation syndrome. It's similar to HLH, elevated ferritins, multiple line cytopenia, hemophagocytosis. Now let's have a look at bacterial pneumonia. So here again, we have direct pathogen signaling, but via a different set of receptors, so TLR2 and 4. But we also get indirect cell damage. So we get cell lysis and release of, again, host damage associated molecular patterns. Signaling, at least at the initiation, is predominantly IL-1 based. We get immune cell recruitment, but here in pneumonia, it's predominantly neutrophils in bacterial pneumonia. So there is a contrast there. Again, we get a diverse range of cytokines released. And a lot of our patients, which is something I've spent really most of my career studying, have an immunosuppressive phenotype, certainly by the time they hit ICU and have been there for more than a couple of days. We see failures of neutrophil function, failure of monocyte cytokine secretion, and so forth. And patients with bacterial pneumonia, or indeed any sepsis, are extremely susceptible to secondary infections as a result. Now, the observant amongst you may have noticed that I've put some asterisks there, and that's because this may all look nice and clear cut, and they're clearly different diseases. Well, is it that clear cut? So interferon signaling is important in both viral and bacterial infections. The precise beneficial and detrimental effects vary from model to model, and there is some evidence to suggest that impaired interferon signaling is associated with worse outcomes in COVID, but may be associated with better outcomes in bacterial infection. the idea that COVID is a uniquely hyperinflammatory disease where bacterial sepsis has this anti-inflammatory or immunosuppressive phenotype is not borne out by what happens to COVID patients who end up in our units. They are extremely susceptible to secondary infections. Half of the patients who come through an intensive care unit who are ventilated will end up with ventilator-associated pneumonia. That's rates that exceed even those in normal bacterial sepsis. And this macrophage activation syndrome or secondary HLH, or however you want to term it, is also seen in patients with bacterial sepsis. So again, it's not exclusive to the viral sepsis that we get with COVID-19. And a lot, particularly early on, was talked about the sort of cytokine storm in COVID. And this is a study where a group from, I think, from the United States, if I remember rightly, looked at some samples that they had from patients with COVID and sepsis patients without COVID. And you can see here that actually the cytokine patterns across the three that happen to have been chosen here don't look all that different between bacterial sepsis and COVID-19. In fact, if anything, the bacterial sepsis is slightly higher. So again, I think this idea that these are really quite distinct pathophysiological diseases with very distinct mechanisms is not the case. Rather, it's about the temporal profiles and when you're getting active pathogen replication. So then the question is, can we translate any of these findings from COVID-19 into bacterial sepsis? So let's take glucocorticoids. I think with the publication of the adrenal study and trigger sept studies and so forth, the use of hydrocortisone for management of patients with vasoplegic, vasopressor dependent septic shock is now pretty much standard in most units that I've worked in, or with people who I've spoken to about this. It's fairly, a fairly well established standard. Even if we're not sure that it necessarily improves mortality, it certainly improves your resolution of shock. Now, that wasn't what the steroids were being used for in COVID. However, they were being used for pulmonary inflammation, which is essentially a form of acute respiratory distress syndrome, or ARDS. Now, the story about steroids in ARDS is much muddier than it is in septic shock. There was this trial that was published coincidentally just as COVID-19 was sort of hitting us, the DEX-ARD study. And that is one of only 2 studies to show benefit of steroids in a mixed population of patients with ARDS. Now, sort of common with all ARDS studies, this was mostly a study of pneumonia. About half of the patients had pneumonia, and another 25% or so had bacterial sepsis. So there is some evidence that steroids might be of benefit in patients with lung injury secondary to bacterial infections. But we also have to remember this is a meta-analysis from more than a decade ago. We have tried steroids in various doses in sepsis before. And what we can see from this study is basically the more steroids you give, the worse the patient does. So I think before we go sort of careering into the routine use of steroids in patients with lung injury, we should be a little bit careful. Again, the debate about whether we should give steroids for patients with pneumonia rumbles on. This was the most recent study in the field that I'm aware of, which was essentially a neutral outcome. And this is a study with the sickest group of community-acquired pneumonia patients yet studied in a steroid trial. So I would say that steroids, certainly there are a number of problems with the studies that we have. There's been heterogeneity in the protocols, the doses that are given, the duration, which drug you use, and there's heterogeneity in the patients, so severity of disease and what precipitated it. In the sort of stress dose, for want of a better term, in vasopressor-dependent septic shock, personally, I feel that's pretty well established and not really much more debate to be had there, except around the margins. The use in ARDS, one single large trial and one smaller trial have shown a mortality benefit. Others haven't. And so I think there is an area where we need to study in more depth. And ventilated community-acquired pneumonia, again, I would say the evidence at present does not currently support its use, possibly an area for future trials. We'll briefly touch on 2 of the other therapeutics which have been proven in COVID. So tocilizumab, which is the IL-6 blocker, contraindicated in patients with infection. And the reason why that is because we know that patients who are on TOSI for long-term inflammatory disease are at an increased risk of severe infection, and that's been shown in post-marketing surveys of this drug. I had a look in the literature for trials of tocilizumab in patients with patients with sepsis, and I couldn't find any at all. The only study I could find was this one here, which had been done in rats. And again, no one should be translating direct from findings in rats into humans. That's been a thoroughly unproductive path in the past. So the conclusions from tocilizumab, in my mind, are much more clear cut. It is contraindicated in patients with suspected bacterial infections, and there may be groups of patients with bacterial sepsis in who it might be of benefit. I'm not ruling that out, but before we even get towards a clinical trial, we need to do an awful lot more work to work up which groups of patients that might be, let alone before we start them in routine clinical use. The other sort of major immunomodulatory drug that we're using is baricitinib, which inhibits the JAK-STAT pathway, which is intracellular signaling from a variety of different pro-inflammatory stimuli. And again, patients who are on JAK-STAT inhibitors, tofacitinib, I'll try and say it right, is the much more widely used one than baricitinib. It's been around for longer, but again, like with tocilizumab, is associated with an increased risk of severe infection. So again, it is contraindicated in patients who you think have bacterial infections. And again, I went to go and have a look in the literature to see if anyone had published the experience of this in bacterial sepsis. And once again, the only thing I could find was in mice with a distinctly uncertain outcome. Maybe makes some forms of infection worse and others better. Again, this is a mouse study, and clearly no one should be translating this directly into humans. So again, the conclusions here, I think, are pretty much the same. There's an increased risk of infection, and therefore it remains contraindicated in patients with suspected severe bacterial infection, certainly. And again, before we took this anywhere near a clinical trial, let alone routine clinical use, an awful lot more work needs to be done. So hopefully, roughly within time, the sort of concluding points here is that COVID-19 is different from bacterial sepsis, not in its fundamental nature. There's a lot of commonality in there in terms of the immune response, but it's when that immune response happens relative to active viral proliferation. The early use of immunosuppressives in COVID-19 might be harmful. And I think, I suspect that the audience is much like my recent experience. We're seeing quite a lot of patients who are acquiring COVID in hospital and are not all that sick with COVID, but are sick with something else. And there's a temptation then to rush in with immunosuppressives, which at that point may not be the right thing. And the evidence is not clear on that area. So the mechanisms which underpin both the systemic and compartmentalized inflammation in these diseases is actually similar. But we shouldn't then jump from that to say that empiric use of immunosuppressive therapies that worked in COVID should be taken straight into their bacterial counterparts. Antibacterials, like antivirals, as Hallie has amply demonstrated, should be given early, at least when you're pretty sure you've got an infection. And the final reflection is that the victories we made in COVID and the massive success that was there were won by carefully conducted clinical trials. So let's not chuck that finding out of the window. Let's not throw away the baby with the bathwater and go back to wild empiric therapeutics. So thank you very much, and I'll stop there.
Great. Thanks, Andy. I think let's probably time for some questions. So can I probably start with Hallie? Hallie, there's a question for you on the, do you want to take the first one on there?
Yeah, sure. So this is a question about, they have a risk stratification tool for sepsis diagnosis and only recommend antibiotics for those considered high risk, but often clinicians overrule this and give antibiotics for moderate and low risk patients. This is a cultural issue rather than an educational issue. How would you advise trying to reduce overuse while still giving clinicians autonomy? Yeah, so this is an awesome question. I think, when I think about this, I think about the sort of decision to prescribe antibiotics across two axes. One, how likely is it that they have a bacterial infection? And then two, how sick they are. And I think the sicker the patient is, the more sort of overuse we need to tolerate because the risks of being wrong are higher. So I don't know exactly what this tool looks like, but I guess I would just say that we need to sort of be a little bit more forgiving. I think the sicker the patients are, and the guidelines the dichotomize around shock. That's probably an oversimplification. There's lots of other ways that people can manifest illness. So I think about, for people with, altered mental status, with elevated lactate, mechanical ventilation, in addition to shock, are sort of reasons why I'd be sort of more willing to potentially sort of overtreat or have a lower threshold of certainty. I still suspect that this tool probably helps. There's this framework called the 4 moments of antibiotic prescribing that talks about sort of different decision points in the decisions to give antibiotics, like, does my patient need them? Have I ordered cultures? Have I thought about the appropriate antibiotics? And then talks about de-escalation. And I think when you sort of set this framework up and you get people sort of prescribing this antibiotics, if they know that they are prescribing them in a patient who's low risk, I suspect that very next day, they're going to be more apt to stop them. So I think it's just important to be sort of cognizant of the reason we start antibiotics, because I know this is an infection, or because, well, I'm not sure, but I'm worried because of this thing, and sort of passing that information along to the next clinician. Because there's also a lot of literature about the sort of momentum, right? So if the ER starts it, you're more likely to continue it. If the physician before you started it, you're more likely to continue it. If you convey, I started this because I really don't know what's happening, but the patient is sick and I'm worried, but I'm, have a high suspicion that it may not be infection, please reconsider antibiotics tomorrow. That next physician taking over care is going to be like way more likely to stop it. So I'm going to put in the chat this, I guess it's only host and panelists. I don't know. Okay,
no, you
maybe
can type an answer to that question.
Oh, okay. Answer live. Yeah.
Yeah, there you go.
Anyway, I'll try to share the thing to the 4 moments of antibiotic prescribing. But anyway, I think it's a good tool, but it's going to be impossible to stop antibiotic prescribing, especially in high-risk patients.
Great. So whilst you are just typing, can I probably bring in Andy with a different question, and then we'll come back to you. So Andy, one of the challenges with immunomodulation is timing, which you highlighted. The second issue is the risk of subsequent secondary infections. Now, one of the criticism leveled at some of the big trials is that the secondary infection data collection as part of adverse event monitoring wasn't as robust as it would be at peacetime. And some of the longer term risks of reinfection hasn't been followed through. So how would you kind of reconcile that challenge?
So that's a really good point, Manu. And I think, it's very clear that patients who suffer from COVID and end up in ICU are extremely high risk of secondary infections. Now, how much of that is due to the immunomodulatory therapies they've been given, and how much of it is due to a sort of inherent degree of immunosuppression that comes from being profoundly inflamed, is, I think, remains a little bit unclear. You're absolutely right that the major trials didn't really, of IL-6 blockers and steroids and so forth, didn't robustly collect secondary infection data. And, it's a very difficult area to adjudicate on whether a patient has a secondary infection, and it's fraught with difficulty. So I absolutely understand why they didn't do that. I think the first thing to say is we have to remember that despite the fact that they are likely to be associated with an increased risk of secondary infections, the overall benefit was clearly there in terms of mortality. So we shouldn't hold off immunosuppressive therapies or immunomodulatory therapies in COVID for fear of secondary infections. Equally, I think we should be cautious about not going beyond what the trials have shown us. So the sort of, 6 milligrams of dexamethasone, good, 1.5 grams of methylprednisolone must be, 10 times as good. Well, the evidence really isn't there for that. And there almost certainly are significant risks of uncontrolled secondary infections. Equally, in the same way as if you were dealing with a patient with immunosuppression from any other cause, you should be watching out like a hawk for those secondary infections. Because again, we know from the ventilator-associated pneumonia literature that if you don't treat VAP properly, mortality goes up. The attributable mortality of VAP remains, again, a point which we can debate endlessly over beers in Brussels at some point. But, it's pretty clear that if you get the wrong antibiotics, and probably if you give them late as well, that your mortality goes up. So watch these patients like a hawk. There is quite a lot of observational stuff, but there are about 4 or 5 studies out now that show an association between the use of particularly steroids, interestingly not tocilizumab, and secondary infections. So I think the risk is definitely there, but it shouldn't stop us using them.
Great. Whilst you catch your breath, let me ask Hallie. There's a question for you, Hallie, on the chat by Benjamin Millett about PCT. Can I also, whilst you're trying to answer that, ask a related question to your study? So one of the arguments about declining antibiotic use with trends is that you give antibiotics to lots more people, a single dose or something, quickly, and then subsequently you don't, because you then reassess your risk profile as you highlighted. Would that have influenced some of the analysis findings that you had in your paper?
Yeah. I think these are sort of great questions. So let me try to answer them all kind of one at a time. So I think this question in the chat asks about sort of stewardship, kind of how did that occur? How did stewardship improve? And was it procalcitonin? So we had a lot of hospitals and it was 6 years. So obviously there was a lot happening on the ground that sort of varied across hospitals and over time. And we were not able to measure that directly, but I will say, like, that's important that this was done in the VA and done in Kaiser, because these are large healthcare systems that have invested in stewardship. So just because we didn't see overuse in our setting doesn't mean that, oh yeah, no, overuse will never happen. You can just sort of focus on time to treatment and don't worry, right? And so I'll type an answer in this chat here too. It's just a study that that sort of summarizes the efforts that were done in the VA for antimicrobial stewardship. So they had a lot of stuff at the high level that were sort of tools available, resources, kind of like templated guidelines that could then be sort of adapted for local use. So there was a lot happening. In terms of procalcitonin specifically, that was not widely available until about 2018 or 19. So I don't think actually impacted really antibiotic use in this study. It used to be a send out lab. And so the turnaround was several days. It was essentially not helpful for clinical practice. And then I think at large, all the VAs sort of bought procalcitonin machines, so it could be done in the hospitals. But again, I'm kind of interested to see how that will have to be the next study, kind of how did that further impact it. And then Manu, you asked about, there's different ways to sort of reduce antibiotic use, like stopping from giving it in the first place, which I think, is challenging for the sort of points that were brought up earlier. And then, limiting the duration, just give a dose and stop. And, there's been a lot of, I think, debate about, the merits of giving a single dose. Certainly there's some sort of theoretical, and I think probably some data suggesting that even a single dose of broad spectrum antibiotics can do harm to the microbiome, et cetera. And so we really do want to sort of focus on both sides. But I also think that there's data showing that, shorter is still better. You shouldn't say, oh, we gave one dose, now we'll just give 10 days, right? Like there's always kind of an opportunity to work on that. I will say, I didn't really highlight it, but we did see a reduction in the prevalence of multi-drug resistant organisms. So we were able to actually measure like VRE and MRSA and all these different pathogens in our hospitals, and that declined over time, and probably just a result of the sort of sum total of antimicrobials being less. So I think probably, Manu, we saw both, slightly reduction in proportion treated in 48 hours, but more profound reduction in the sort of average days of therapy. And that probably is because there was more people who got like a dose or two and then stopped.
Yeah, great. So I'm going to kind of try and bring you both into one question. So Andy, your argument could be interpreted as, hey, kind of pathogen is there, but actually the host is a better target for intervention, whereas Hallie is saying, hey, host is great, we can support it, let's target the pathogen. So how do we kind of get together?
So I mean, I think the answer is we should do both. I wouldn't in any way advocate trying to treat sepsis, bacterial sepsis, without antibacterials. I think that would be madness. What we need to do is make sure that we're targeting the right pathogens at the right time. We've got to identify the pathogens early, get the optimal antibiotics into these patients, and try, where possible, to move away from empiric broad spectrum antibiotics for prolonged periods of time. We should be narrowing down and targeting the organism. But in order to do that, we've got to have far, far better diagnostics. Now, infection is fundamentally a pathogen and the host response. If you don't have both together, you haven't really got infection. You've either got colonization or contamination or a dead host, pretty much, which is also largely uninteresting. And so, I think we need diagnostics that combine both of those things, that you've got the host response that you can say, this is definitely infection. You've got the pathogen, you say, this is the nasty organism that's causing the trouble. And then you need to target both. Now, the bacteria are kind of relatively easy to target because if you're given something that kills them, that's great. The host is a much more complex thing because there's temporal profiles of both pro and anti-inflammatory things going on at the same time, and so forth. I will hold my hand up and say I was utterly wrong about COVID at the start. I, was very skeptical that these immunosuppressive therapies were going to work. I said so publicly. I was completely wrong. And I have recanted, and I use them just as everyone else should. The evidence is really clear. But I do, I worry about bacterial sepsis and how we'll tease that apart, and when do we know what to use. And steroids particularly, I mean, they're lovely because they're nice and pluripotent, but they're a real blunderbuss. So it'd be nice to be able to sort of target specific mediators at specific times. But I think we're probably at least a decade away from that in bacterial sepsis.
Hallie, anything to add?
Yeah, I mean, that was an amazing answer, and I completely agree with everything Andrew just said. I mean, I think it's something, we need to target both. Certainly treating the infection is important, but I think, all these kind of classical descriptions of sepsis is, this is infection that has caused this kind of dysregulated response such that even when you treat the infection, some people continue to have, ongoing organ damage and issues. And it's like the host response has been sort of set off. And if you don't also address that, just, throwing more antibiotics is not going to necessarily solve all of those cases. We sort of need to address this from both directions. And it would be great to sort of be able to understand, when has the infection been eradicated? So I don't just continue tossing these broad spectrum antibiotics at a certain point, just aren't going to be helpful anymore. And it's really about this kind of ongoing, host response that hasn't sort of returned back to normal. So, yeah,
I think probably time for one more question. So both of you talk about timing in a very different way. Andy talks about optimal timing, and Hallie speaks about timing from door to needle sort of timing for antibiotics. Now, Hallie, do you really think that 37 minutes gained over the last 6 years is just kind of influencing outcomes from sepsis?
Yeah, right. It's a great question. 37 minutes is not going to sort of translate into a lot. And obviously there's a huge variation, it's like that hour mattered a lot for that very most sickest patient, right? And so I do think when you think about, where are you going to get your most bang for your buck? I think the sicker the patient is, the more likely you are going to get bang for your buck for focusing on them. And it's interesting. So we looked at this kind of, what's associated with delays in time to antibiotics. And you'd think that the sicker people are getting antibiotics faster, and it's not necessarily always the case. Some people show up sort of altered and hypotensive, and they don't have those classical signs and symptoms, and they can't tell you a story. When these people come in, I think those are the people that we really need to focus on to sort of treat early and de-escalate, because when you show up with sort of undifferentiated shock from a nursing home, chances are sepsis is a really good cause of that. And if you're just kind of focusing on the hemodynamics and not sort of the risk for infection, I think those, things can get very bad. And then once that host response is sort of set off a bad path and you treat later, it's like the avalanche is already going down the hill. So 37 minutes, in all comers is not going to translate into this big thing. But sort of an hour in certain patients is going to be a difference,
Great. Andy, immunomodulation and timing?
Yeah, so I mean, it's pretty clear from various groups, including work that you've done yourself, Manu, that the sort of suppressive phenotype that we see, certainly the features of that occur pretty early on immunologically, even though they only manifest themselves as secondary infection later on. That's probably just a sort of simple function of time at risk. And so the question is really, do things divide neatly into phases of immunoactivation and immunosuppression? No, I think that's now pretty clear. So how do we disentangle these, and how do we choose which ones to go after? When should we try to immunostimulate? Should we try to immunostimulate anyone? Again, I mean, the evidence for that is not exactly stellar at the moment. And I think at the moment we simply don't have any answers. What we sort of coming back to the previous answer, what we need to be able to do is phenotype these patients well enough to identify patients who we can then do the trials in and see whether these things work or not. I'm very, very cautious about empirically doing this, without that evidence, because the potential for it to all go horribly wrong And I think that's the other thing that COVID taught us. You know, obviously some people were using steroids empirically from the start and tocilizumab empirically from the start. Turns out they were right, but there were also people who were using, you know, ivermectin, hydroxychloroquine, and everything else they could find in the back of the cabinet that once had an antiviral effect in a plastic dish, and they were wrong. So you cannot sort of use I used empiric therapy and I was right as justification for carrying on doing that.
Well, with that lovely summary, Andy, I think we should wrap it up. It's 2 o'clock in the afternoon, and thanks again, Hallie and Andy, for the lovely and interactive session and the wonderful audience. Thank you so much, guys.
Cheers, guys.
Thank you.